Hello, I'm Dr. Cesar J. Bravo, the Program Director of the Virginia Tech Career Enhanced Surgery Fellowship. And today we'll be doing an interesting topic in what is new in hand surgery, and we'll cover the years 2021, 22, and 23. This is based on the guest editorial provided by the Journal of Bone and Joint Surgery. It was initially the first one we reviewed was by Dr. Christopher D. And then subsequently, that was in 2021. In 2022 23 was by Dr. Deborah Bond from the University of Minnesota, Minneapolis, Minnesota, which these are excellent reviews, and we do reference these for our listeners to go over them. And this initially started with an idea that I got from listening to the Upper Hand podcast, which is Dr. Christopher D. and Chuck basically talk hand surgery, and this is an excellent podcast to listen to if you have interest in hand surgery. They cover all aspects of hand and upper extremity surgery, and it's definitely one of the things that I recommend our fellows to listen to because it definitely has a lot of practice applications. Again, this is hosted by Dr. Chuck Goldford and Christopher D. And this is where initially they had different hand and upper extremity updates that were in. This is where we got the idea from. Starting with our bread and butter of what we do in our practice, which is carpal tunnel syndrome. And one of the things is in 2021, Nkrumah demonstrated that severe carpal tunnel can be established by using sonographic measurements of the median nerve at the carpal tunnel. And basically, they showed that a cross-sectional diameter greater than 12 millimeters was found to be highly specific, predictor of severe CTS. This was, there was another study in 2021 that was done by Green et al., and they basically were able to show that when you do a carpal tunnel stimulated injection, that it's not a benign procedure. They were found that about 8.7% of the needle was placed into the median nerve. The carpal tunnel was missing approximately 15.6% of the time. So as we're doing these carpal tunnel injections, carpal tunnel cortisone injections, we need to be aware of our anatomy. And definitely sometimes using ultrasound may be one of the benefits of doing this procedure combined with ultrasound. Billy et al., they found that 6% of patients undergoing carpal tunnel release were prescribed gabapentoids. And this is one of the things that, as we are practicing in surgery and hand upper surgery, the use of less narcotics as well as neuromodulators. And these patients that were on neuromodulators less than 3 months prior to the carpal tunnel release were more likely to continue with post-op gabapentinoid and opioid prescriptions greater than 90 days post-operatively. So this is definitely something to consider in your patient population. If this medication can be modified, that these patients are not in this significant nerve modulators or narcotics, it'll be a great assistance to your practice. As we continue with carpal tunnel in 2021, and Nkrumah, they were able to demonstrate, that when questioning patients with regards to their symptoms of improvement, most of them what was more likely that they reported was that it improved their sleep, and nearly 50% of the patient had improvement in their sleep within 24 hours following the surgery, while the remainder had improvement within a week. So this is something that even in the chronicity of those patients that have carpal tunnel issues, long-standing the nighttime relief is something that can be predictable if it's a true carpal tunnel syndrome. Gil et al., they performed a randomized controlled trial of therapy after carpal tunnel release, and this is something we always question, so we always need therapy in these patients. And they looked at patients who underwent mini carpal tunnel release and were randomized to one of three groups, either no therapy, one therapy session on the post-op day 10, or 6 weeks of standard formal therapy. And they were able to show convincingly that they did not find a difference in outcomes and return to work. Although their study was underpowered and there was a substantial crossover among groups, the average return to work time ranged from 16.6 to 21.8 days, which is approximately 3 weeks. So this is also something that you can inform as patients ask you when can they return to work. And this study showed either with or without associated therapy after carpal tunnel release, 3 weeks was approximately the average as well. As we move into 2002 with carpal tunnel, the role of electrodiagnostic studies compared with clinical judgment was found that the utility of EDS tests may be greatest in patients whose diagnosis of carpal tunnel is questionable. So that kind of leads into the other tools we're currently using, which is the CTS-6, as well as also a 26-point scale Boston questionnaire that incorporates aspects of history and clinical exam to predict probability of carpal tunnel syndrome. Definitely, this is a less expensive tool like a CTS-6, and basically will likely, these measurements in addition to ultrasound will likely supplant the use of electrodiagnostic studies in carpal tunnel syndrome. Lupton et al. They looked at decreased sensation. I thought this was after a digital blog, and this was a great study in that they were able to show that the thumb being numb had the greatest negative impact on dexterity, and that loss of sensation in the index and the long fingers that caused the decreased grip and pinch strength. This explains the common symptoms of patients telling that they drop things, they lose dexterity and strength in patients with carpal tunnel syndrome. And as we move into and continue in 2022, Gardacio randomized patients to opioid and non-opioid medications after carpal tunnel release, and they were able to show that there was no difference in reported satisfaction. In the non-opioid group had a lower NPR and a quick dash score. So in summary, the summation of the literature on this topic indicates that prescribing opioids after carpal tunnel surgical procedure is not recommended. DeRue et al., they suggested that a simple repeat release of recurrent symptoms is adequate, and they were kind of questioning the need for wrapping and placing flap over the nerve in this well-done study. So these are things to consider. Definitely in your practice, the use of narcotics in our practice here definitely has diminished to almost zero. As we move in 2023, I think the ultrasound kind of really has to move into the scene more and more, as we've seen with the different studies showing, and we'll mention a few. And Gardacio, again, recent studies show that CTS-6 scores were similar when they were applied either by inexperienced or inexperienced individuals. And this was with an assessment was made via telemedicine, including indicating that CTS-6 is easy to administer and reliable. In Charles et al., they also compared ultrasound with electrodiagnostic studies and confirming the clinical diagnosis of CTS. Patients who had carpal tunnel diagnosis confirmed by a surgeon using ultrasound had 1.8 fewer medical visits and underwent a surgical procedure 3 to 4 weeks earlier to those who had a CTS diagnosis confirmed by EDS. And again, this is showing Dr. Fowler and his team the power of the ultrasound in the sense that it's going to eventually supplant the EDS studies. And severity of CTS as measured by the ultrasound positively correlates with the severity as measured on the EDS. Again, Fowler continued with this study that they showed the cross-sectional area of the median nerve was compared with the severity of the changes of EDS based on the American Association of Neuromuscular and Electrodiagnostic Medicine guidelines. And they were able to show that increasing surface area correlated with specific sensory and motor electrodiagnostic measurements. A cutoff of greater than or equal to 10 millimeters squared showed the ability to discriminate between normal versus abnormal electrodiagnostic studies, and a cutoff of greater than or equal than 12 millimeters squared indicated differentiation between mild CTS and moderate to severe CTS. Again, continue with the ultrasound theme. Ultrasound and CTS have been shown to be more sensitive and specific in diagnosing carpal tunnel syndrome than electrodiagnostic studies. So this is a very powerful statement. Definitely this is a change, a paradigm change that we've seen over the past 10 years with regards to carpal tunnel syndrome. One of the things in 2023, Penn et al., they were able to show strong evidence with the use of corticosteroid injection in the treatment of CTS. In their group, they were able to have a 90% follow-up of the original cohort study. So they've had a total of 3 studies, eventually led to the third one, which is continual follow-up in 6.3 years. And they were able to show that in 11.6% of the surgical group and only 41.6% of the injection group had a therapeutic failure, meaning that 58% of the patients randomized to corticosteroid injections for the carpal tunnel syndrome needed no further treatment. So this is a good study to take a dive in, look at the perspective and what it has to offer. So it still does show some benefits from the corticosteroid injection, and this is always something to think about, as this kind of has shown some good evidence. Amyloidosis, we know, is a potential lethal systemic condition resulting from extracellular deposition of precursor proteins, including tenosynovial and cardiac muscle tissues. And in a diagnosis of carpal tunnel syndrome and trigger finger precede the diagnosis of amyloidosis by as little as 3 years. So in this study, the Veneto found that tenosynovium from 29% of the men greater than 50 years of age and women greater than 60 years of age tested positive for amyloid on Congo red staining. So this is in these patients that present with bilateral carpal tunnel syndrome, in addition to also trigger finger. Do consider, sometimes it may be of benefit of doing the Congo red staining. And this is where us as hand surgeons can really impact the treatment of this disease, because definitely the heart issues that can develop after the diagnosis is a precursor. So we're able to identify it and treat it early now with the newer medications available to treat this. ASCAR reported that 7% of 114 patients who were 46 to 80 years of age and had bilateral CTS had amyloid. So again, positive for amyloid and Congo red staining. This is something to look for and to maybe considering these patients that we as hand surgeons can really provide an impact to our patients. As we move from carpal tunnel to cubital tunnel syndrome, in 2021, Yeoman found that the vast majority of patients were satisfied with their in situ decompression. However, those patients that were not satisfied, they were able to correlate that they had significant pre-op weakness of muscles innervated by the ulnar nerves. So it may be in those patients that we have significant atrophied involvement, and subsequently may be a need that when advanced stages that we may consider transposition. Felder et al. They reported the results of using a cross grafts from median to ulnar nerve in the palm to improve sensation in advanced stages of carpal tunnel syndrome with profound sensory loss. And what was interesting, they were able to show the improvement in sensation to a varying degree in all patients. About 87% of the patients regained protective sensation alone and did not experience improvement in light sensation, static 2-point discrimination, and monofilament testing in their results. But definitely this is a powerful tool, especially in these patients with advanced profound sensory loss, that we can consider these cross grafts from median to ulnar in the palm. One of the things is we move in peripheral nerve brachioplexus in 2021. One of the things is Loewe et al. They may cause surgeons to reconsider the use of compromised FCU branch. In 91% of the cases in which the FCU branch was used to restore elbow flexion, among a variety of injury patterns within the context of different surgical strategies, 20% of the cases were considered unsuccessful. So in some of those transferred nerve transfers that we're doing and their involved branches, we need to be mindful of the possibly lower expected outcomes that we may get. Bertelli reported the results of a study in which 14 patients who presented less than 12 months from injury who were treated with nerve transfers and 13 patients who presented greater than 50 months from injury and were treated with tendon transfers. One thing that they were able to show in Jamie's studies is that restoration of wrist extension was reliable after both techniques, but a greater arc of motion was seen among patients who had the nerve transfer. That may explain the powerful of nerve transfer as compared to tendon transfer, where you have separate finger extension instead of composite extension. And finger extension was reliably restored in all patients with tendon transfer. Among the patients who underwent nerve transfer, 12 had M4 extension, but there were 2 causes of complete treatment failure with regards to finger extension. But both groups, full MP extension was not restored, and with an average of lag of 30 degrees. And this leads to the question that, because we've seen with nerve transfers, for radial nerve transfers, PIN nerve transfers that we do, that our thumb is not predictably obtained. And that has led to other considerations that we'll mention here that he reported, Bertelli again, and their team reported, the transfer of the distal branch of the AIN, which is transected years prior to innervating the PQ, pronator quadratus, to the deep branch of the posterior synostoid nerve. And prior to intervention of this muscle, the first, second, and third dorsal compartments is what we're providing intervention, as shown in the picture here. And this may be a good, reliable way to add to your nerve transfer in order to increase your thumb dysfunction that may be residual, as shown in the other slide, at 30%, 30-degree extension lag. This leads to the supercharged reverse end-to-side nerve transfer of the AIN in treatment of ulnar nerve injuries continues to grow. There's data now stating that it's been as reliable, but Corium reported their experience with treating 21 ulnar nerve injuries, 10 treated with repair alone, and 11 treated with reverse end-to-side. No patient underwent end-to-end nerve transfers. The patients were included in this randomized study if their injury was above the elbow or up to 10 centimeters distal to median epicondyle. And they were able to show that the reverse enthesitis did have increased regain in their intrinsic function. Again, there's increasing evidence that patients with spontaneous peripheral neuropathy, such as AIN nerve palsy, after shoulder procedure, what is known as posterior interosseous nerve palsy or Parkinson syndrome, may benefit from peripheral nerve decompression and spontaneous recovery is not present early. And Bertelli, again, and his team, they were able to assess adequate pinch assessment, and they recommended that in order for us to adequately assess the adduction strength of the patient's thumb, they're instructing the patient to pinch at the palmar IP joint rather than the thumb tip, thus isolating the thumb adductor. Multi-center study that looked at processed nerve allografts demonstrated that it was better than conduits in patients with small, less than 14 millimeter, and large, 15 to 25 gap defects in terms of functional recovery. And targeted muscle reintervention. This has come into the field as a promising results with decreasing pain after amputations, and techniques like this should be now considered standard of care. As we move from peripheral nerve discussion, now we move to basal joint arthritis. Again, a common theme within our hand practice is a lot of this condition that we see on a regular basis. So in 2021, Ottenhoff, they were able to show low agreement among surgeons as to which type of treatment to offer. And it was shown that surgeons are more likely to recommend apparatus treatment situations in which patients report more severe pain, have not seen relief in prior intra-articular injections, or have more severe radiographic arthrosis. Less likely to recommend surgery if patient exhibited some substantial depressive symptoms, suggesting that surgeons are aware of the influence of mental health on prognosis after treatment. Shaw et al., they demonstrated that LFTR with a split FCR tendon more closely resemble intact FCR forces in the muscles crossing the wrist compared with trapezius excision, suture suspension arthroplasty, and silicone implant arthroplasty. Lane et al. In a UK hand registry data that both trapezius excision alone and RTI led to improvement in patient-reported outcomes and health utility. Improvements continues up to a year after the surgery. Again, multiple ways to address this problem, but it looks like removing the offending structure of the trapezius seems to be common in all these studies. That actually leads to good results. Continue with CMC arthritis in 2022. There was 3 studies that showed that there was a relatively low number of patients who later underwent surgical procedure in the study period. Only 13% go on to surgery within 5 years. So not everybody that shows up with thumb arthritis in your clinic will go on to surgery. Baca et al., they demonstrated 121 CMC joints with trapezius excision and ligament reconstruction with tendon interposition over a 12-year period. They noted greater improvement in the post-operative quick DASH score reported by patients who underwent LFTI within less than 2 years of symptoms onset, compared to patients who underwent LFTI within the greater than 2 years of symptoms onset. So meaning there was greater improvement if the symptoms have been going there for much less time as compared to a longer period of time. Longer-term follow-up mean of 17 years after a randomized trial comparing trapeziectomy and trapeziectomy with LFTI showed no difference between groups in terms of pain, function, satisfaction, and strength. Again, pretty good long-term study. These are things to consider in your patient population when you're treating them for CMC arthritis. In 2023, Dr. DeGeorge and his group, they were able to show safety and efficacy using twice daily topical application of 6.2 milligrams of CBD cream, and they were able to show yielded significant clinically meaningful improvement in pain with an improvement in mean visual analog scale, as well as in DASH scores, which improved. Again, this is a mixture of shea butter with the 6.2 milligram cream or just shea butter by itself, and they were able to compare and show quite nicely that it did have some good improvement. So this may be something to consider in addition to your practice. Tofik et al., they showed the general use of corticosteroid injections in CM arthritis does not negatively impact the outcomes or rate of complications of CMC joint arthroplasty even when greater than 3 injections have been given. Again, going back to the George study, there was a deregulation of the CBD, in the high public interest of cannabidiol, and basically in 2018 it was deregulated and now provided as an over-the-counter treatment with arthritis-related pain. So again, mixed with shea butter, they were able to show that this dosing is 6.2 milligrams yielded good, significant clinical meaningful improvement. We continue with an arthritis theme. Retrospective review of 88 PIP joint silicone arthroplasty showed no significant difference between dorsal or volar approach with respect to final range of motion and complications. Overall rate of complications of 34% and 16% rate of revision for surgical procedures. So this is something to consider as you talk to your patients undergoing this procedure. Another study was able to show that 114 PIP joint silicone arthroplasty showed high reoperation rate at about 14%. What are the risk factors associated to this increased rate of reoperation? It was a surgical procedure of the index finger, smoking status, non-Caucasian race, and arthroplasty performed for post-traumatic arthritis. So these are things to consider and be mindful in those patients that have these criteria and be on a high lookout for possible complications. Moving into distal radius fractures, in 2021, Ganglion et al. They examined the volar cortical angle, and they were able to demonstrate that this volar cortical angle ranged from 23 to 43%, as shown in the bottom picture, with a mean of 32 degrees. And we know this volar cortical angle decreases with age, and men have on average a larger volar cortical angle, suggesting that current place may fit the volar cortex of the elderly female patients better than younger male patients. And this is important as we use volar locking place, that they have a fixed angle between 18 and 30 degrees, so there's a substantial chance that there will be a mismatch between the patient's volar cortical angle and the implant, so it may have to adjust the implant. Coupled with the work of Wurtzel, who demonstrated that undercorrecting the sagittal tilt may increase contact pressures with the flexor pulsus longus, as shown in the bottom picture. It does give us to reconsider the reliance on fixed angle feature on the volar locking plate for reduction during the distal radius fracture fixation. So you need to be mindful of your sagittal correction. Make sure that you reestablish that loss of volar tilt, because that loss of volar tilt increased with wrist extension in higher Soon grade then can lead to tendon issues. And again, just to emphasize, the loss of volar tilt, increased wrist extension in higher Soon grade can basically lead to contact pressures within those flexor tendons. In 2021, as we continue with Zimmer, they were able to quantify the dorsal ulnar corner fragment, which we know is very important with regards in the sagittal reduction and the stability of this or joint. And they demonstrated that the dorsal ulnar corner fragment in part compromises about 24% of the articular surface of the intermediate column, suggesting that a unicortical cervical screw at times may not be enough, especially when we use that less than 75% rule over the width of the radius, that may not actually secure these fragments. So in some of these large fragments, either longer screws or dorsal approach might be of benefit. Haverda et al., they looked at the complication rate of distal radius with regards to osteotomies, and they were able to show that it was nearly 50%, meaning that there's a high possibility of complication rate, and you just need to be aware of the risk, and aware of the risk or delayed rupture of the EPL tendon associated with these fractures as well. So it may be part of the procedure when you're dealing with this malunions, non-unions, to address the EPL and decompress it. And the risk of delayed union is actually higher in the distraction type compared to those with hinge osteotomy. So again, this is something to consider in your reconstructive patient population with regards to distal radius, malunion, or non-unions. As we continue with distal radius in 2022, Clifton et al., they demonstrated that an interarticular distal radius fracture with radiographic evidence of scaphoid and interosseous ligament injury treated with a locking plate, and no attempt was made to repair the scapholunate interosseous ligament in the injury group. In 12 to 24 months, up to 2 years, there was no difference between the groups with respect to reported pain or function. So it does come to question if we do have to do these acute scapholunate ligament repairs and associated distal radius fractures with interarticular involvement. Knowledge of specialized image intensifier views is of paramount importance, and is something that complements your practice as you treat these distal radius. And remember, the supinated view assesses the rate of styloid penetration as shown here. The dorsal tangential view does assess for the dorsal cortical penetration and may help minimize these technical errors as shown in the picture. Imprint problems may not become evident in the short term, but as Moriah et al., they were able to report in those patients that had flexor tendon issues, they presented with up to a delay of 9 years, so it's not always acute. So always be mindful of your hardware placement and do follow some of these patients closely. And it may be that delayed presentation of tendon ruptures in a poorly placed plate or a plate that actually has migrated can lead to tendon disruptions even later. And again, this is showing the dorsal tangential view. Continue with Distal Radius in 2022, a study conducted in Pakistan showed further evidence that surgical treatment of distal radius fracture in the early population does not portend better functional outcome than casting. In younger patient population, Goa et al., they were able to show that 90% of the patients return to weight-bearing yoga-type activities at a mean of 7 months. So this is something to let your patients know, as it may take a little bit before they're able to do these hyperextension weight-bearing type activities with their wrist after fixation. The risk of surgical treatment of distal radius fracture seems to be no advance to discontinue antithrombotic agents in patients undergoing outpatient distal radius fracture for surgical procedure. And smokers are almost twice as likely as non-smokers to have perioperative adverse event of any kind in the 30 days after the surgical procedure. So this is, again, something to be mindful. In 2023, as we move in distal radius, Kim et al., they evaluated the risk factors for delayed onset carpal tunnel syndrome in patients greater than 60 years of age. And they were able to show that 12% of these 216 patients developed subacute CTS. And important to note that the mean time to diagnosis of CTS was nearly 3 months, so 89.9 days after. And sometimes this is actually a time that they already may have been discharged from your care. So this is always to advise patients that may have residual malangulation, loss of sagittal tilt, and continued dysfunction, that they may develop delayed onset carpal tunnel syndrome at sometimes. It's important to advise your patient with regards to this finding. As we move in Scaphoid Nonunion 2022, Hegesy et al., they were able to do a very nice randomized clinical trial study of Scaphoid Nonunions where they looked at comparing cortical cancellous and cancellous only bone graft. They were able to show that union rates were not significantly different, but the malunions were higher in patients with cancellous bone graft only. The quick dash was significantly better in the cortical cancellous group than in the cancellous only group. And this result suggests that, not necessarily always using cortical cancellous is needed, but those that require significant deformity correction is important. It may be better to use cortical cancellous grafts. As we move from scaphoid, we move to hand infections in 2022. A nice study by Malji and al. They were able to use what is known as a maceration dressing, which consisted of a warm, moist gauze, Curlex, rubber, orthoglass, and a heating pad, similar to a dry dressing. And they were able to show that this moist macerated dressing has significantly shorter hospital stay and duration of IV antibiotics and decreased need for surgical irrigation and debridement. Henry and Lundy demonstrated that patients with acute direct inhalation of osteomyelitis of the hand could be successfully treated with successfully matched oral antibiotics, which is a dramatic cost of reduction from $482 to $21,000 per patient. So if you have the bacteria, the organism identified, directed oral antibiotics might be as effective as IV antibiotics, especially for hand infections. Again, in hand infection 2022, there was multiple studies, and one of the things of looking at multiple studies and reviewing them is what did they show, and they have something that we were able to notice, that poor prognosticators, and those were that patients that had arterial calcification had significantly risk of surgical infection if their serum albumin was less than 3 grams per deciliter, as compared at a 3.5% rate, compared to 0.9% of those that had a greater than 3.5 gram per deciliter. Hemoglobin HA1C, multiple studies quoted greater than 7%, where it would have a higher index of infection for the hand. In 2023, and overall, these studies come to wrap up in the same theme from 2021 and 22, that strong consideration should be given to avoiding ipsilateral hand surgery within 90 days after a corticosteroid injection. There has also been professional consensus in 2015 that has recommended against the use of prophylactic antibiotics for clean hand surgery. They cite low rates of surgical infection whether or not antibiotics are given. In this study by Stain and Fowler, they were able to show, again, further corroborate this information with regards to doing this procedure and not using antibiotics, with regards to doing Carpal Tunnel Syndrome and not using antibiotics. And they noted that it did not lower the rate of surgical infection in the cubital canal after in cubital tunnel surgery. So again, does corroborate with soft tissue procedure in the hand that preoperative IV antibiotics are not needed. As we move into the pediatric population with regards to hand surgery, in 2022, Hutchinson et al. They looked at 93 thumbs in 78 children presented with pediatric trigger thumb over 5 years, and they broke them into 3 categories. And one that has spontaneous resolution with less than 5 of IP contracture, 5 degrees of IP contracture and no triggering, parental request for a surgical procedure before the 5-year completion, and incomplete resolution with greater than 5 degrees of flexion. So they were able to find that 32% had spontaneous resolution, 43% likely to proceed with the surgical procedure a median of 4.1 years after presentation, and 25% unresolved with greater than 5 degrees of flexion contracture. So what's to take from this study is that risk factors for failure of spontaneous resolution were present with those that had greater IP contraction, specifically greater than 30 degrees in bilateral involvement. And spontaneous resolution was associated with presentation of less than 30 degree contracture at the IP joint. So this is something to be mindful as you're seeing these patients in your practice. The less contraction, the more likely they're going to resolve their trigger thumb at the IP joint. That leads to pediatric fractures seen in hand practice. One thing is that malrotation is not present. Extra-articular phalangeal neck fractures in children remodel and have a good functional outcomes without surgical procedures. But again, you have to make sure no malrotation because that does not correct as predictable. Lynch et al. Reported 36 patients with distal radial fracture and a mean age of 8 years who were allowed to heal with medial coronal plane angulation of 17 degrees, as shown in this picture. Fairly remarkable coronal deformity. But they were able to show quite nicely at 6-month follow-up, the median coronal plane was 3 degrees. So it does correct. So we may be able to accept significant coronal plane deformity in these patients. And again, less than mean age of 8 years. And again, a coronal plane angulation of 17 degrees. The different fracture pattern, though, is Salter Harris 3 and 4. This already showed that 12 out of 28 patients had growth arrest, meaning 43%. Thus, children with these unusual distal radius fracture patterns should be monitored closely, specifically those with Salter Harris type 4. Seiler et al. At 6-month follow-up showed that there was no difference in the appearance of the nail plate, meaning calling to question the need for nail reinsertion in a volus pediatric nail without laceration or fracture into the nail bed or fracture at the distal phalanx or the tuft area of the distal phalanx. Let's lead to the hand pediatric update of 2023. Hill et al. They repeatedly showed that buccal fractures of distal radius may be safely treated with minimal molestation for comfort and patient-directed return activities. So buccal fractures, definitely we can brace them. They don't need to be casted. There remains unease, though, about how to best treat these patients less than 10 years of age with distal radius fractures that are 100% displaced and overriding, despite the evidence from 2012 that in favor of inside mobilization. Bradley et al. They were able to show that 72% of the patients in the reduction group had unacceptable alignment at some point in their follow-up, requiring more treatment with regards to additional manipulation as well as cast modification. So again, bringing back to the data again that these fractures with significant displacement might be with the distal radius fracture in favor of inside immobilization. Newer evidence has shown that up to a third of pediatric trigger thumb resolves spontaneously within the 5 years of presentation, as previously shown in the previous quoted study. And those children who do undergo a surgical procedure benefit from local anesthetic ingestion before incision. So if they have a greater than 30 degree IP flexion contracture, they have not resolved, and you're going to do the surgery, it would be of benefit to provide a local anesthetic prior to your incision. Looking at the pediatric ganglion cyst, this is a great article done by Dr. Abzug and his group. that they were able to look at different forms of either surgical or non-surgical excision of these ganglion cysts. And they were able to show that surgical excision was associated with resolution of the cyst in 73% of the patients. Observation had the highest rates of resolution compared to aspiration. Orthosis, fabrication, and observation had similar rates of cyst resolution. Surgery obviously had the highest rates of resolution when compared to observation and aspiration. And what they kind of were able to retrieve from this data is that patients older than 10 years of age were less likely to have the cyst resolve with observation, and those with younger than 10 years at greater than 2 years follow-up had more of a resolution, or basically of that cyst. So the expense of a wrist orthosis or cyst aspiration is not warranted over simple observation, and that a surgical procedure should be judiciously offered to patients with persistent pain and functional limitation. And again, these will more likely be older patients, greater than 10 years of age. As we move into hand fractures, in 2022, Trickett et al. They demonstrated that the distal IP joint in bony mallet injuries demonstrated that of 168 fingers subluxing 50 of those 168, final follow-up, there was no difference in range of motion, extensor lag, or patient evaluation measurement between groups. They recommended non-op manners for osseous bony mallet injuries, regardless of fragment size or subluxation. Furthermore, osseous mallet injuries treated with surgical procedure have a high major complication rate. So this is always something to consider, something that has definitely changed in our practice. Angulated fifth metacarpal neck fractures treated non-operatively, we've known to have good outcomes regardless of the residual angulation. And there's a growing body of literature that IM headless compression fixation or intermittently headless compression screw fixation for long bones of the hand metacarpal heal quickly, early return to function, and minimal need for mobilization. This led to this study in 2023 by France et al. That they identified 15 patients with fifth metacarpal neck fractures that heal with angulation of greater than 70 degrees, which usually that's our upper limit. And they were able to show that 80% of these patients had no disability on their Quick-DASH score, and all patients scored less than 10, indicating minimal morbidity. So again, it does favor the metacarpal neck fractures non-operative treatment. Pagani et al. They reported on 24 Major League Baseball players, and this is just a captive population, and they were able to show that those players treated non-operatively missed significant fewer games than those treated operatively. So again, this is something to consider. It may change a practice pattern in this subset of select group of patients. As we move to flexor tendon repair in 2021, Irwin et al. They compare the biomechanical properties of using a tendon coupling device, which basically consists of a low-profile stainless steel staple plate in each tendon stump, bridged by a polyethylene thread, or an 8 locking strand cruciate repair. They compare these, and the mean load to failure was significantly higher for tendons fixed with a coupling device compared to tendons fixed with an 8 strand locking cruciate repair. So the coupling repair was 4 times faster than the 8 strand. So this may change a lot of the, specifically those some ones that we're only doing FTP repairs. It may be something that may be of good use or to have in our toolbox, but only time will tell. For flexor tendon repair, one of the articles that by Dr. Compton et al., as well as Charles Goldfarb, they reported the results of 11 patients treated with non-repair of some 1 FTP injuries, and they were able to show that the non-repair group had a better objective outcomes in terms of distance from the fingertip to the distal palmar crease, the number of patients unable to touch the finger to the palm, 1 compared to 8 patients in the repair group, but had much lower costs and much fewer complications and therapy visits in the group that underwent primary repair. So again, this comes to play more in the chronic presentation of a patient with a zone 1 injury, flexor tendon, that we might consider non-op treatment in those patients. Leading to Dupuytren's contraction in 2021, Leafball evaluated single surgeon treated with neuroponeurotomy, collagenase injection, surgical fasciectomy over an 11-year time frame, and they were able to show that the rates of reintervention with neuroponeurotomy was 24% at 2 years and 61% at 5 years. Collagenase at the same time were 41% and 55% respectively. Surgical fasciectomy had the lowest rate of reintervention, 4%. And again, The cost with collagenase compared to neuropanoramic was 6.7 times higher. And the more severe the PIP joint contraction at a younger age at the time of initial intervention were predictive of reintervention after collagenase and neuroporotomy. And again, fasciectomy has a higher initial cost but a lower reintervention rate. So this is something to consider. And this kind of theme has evolved as we look into 2003, that now few studies that show 5-year results of collagenase, Clostridium histologum, injection of Dupuytren compared to other treatment methods. And the consensus is CCH provides little to no benefit over percutaneous needle fasciotomy in terms of recurrence or reintervention, but it's much more expensive. Both treatments have a similar 5-year recurrent rate, around 50% in comparison. The rate after surgical fasciotomy, as previously said, is 4%, is much lower. So there may be a subset of patients that needle panoramic might be the more cost beneficial approach, but in some cases that you have that nodularity type Dupuytren contracture, and some of those patients may also be a benefit of the collagenase injection. So definitely something to consider as you treat your patients with Dupuytren contracture. Quan et al., they reviewed 58 patients who underwent fasciectomy, some who had received intraoperative 10 milligram IV dose dexamethasone followed by a 6-day taper of metro dose pack, and some who did not. They were able to show at 2 and 6 weeks the cortical injection group with the metro dose pack had better range of motion and hand function. And if you're doing limited fasciectomy, sometimes the flare afterwards and the recovery, it's it may be a little more difficult, and that's where maybe considering some form of intraoperative IV dose dexamethasone and a metro dose pack might be something to add to your toolbox, especially if you're doing these wide awake, which hits the growing trend as well. In Trigger Finger in 2021, 2 recent studies have examined the relationship between corticosteroid injection and subsequent infection. And again, Matson et al., they looked at 2,480 digits among 1,857 patients, and they had 53 infections, 2.1% of the digits. 41 were superficial, 12 were deep, but corticosteroid injection was performed less than 90 before surgery. The likelihood of having a deep infection was 6.5 times greater than if the cortisone injection was performed greater than 90 days. Again, going back to that point of waiting the 90 days after cortisone injection before doing any procedure within the hand. This overall risk of infection is low, but consider waiting to perform surgery until at least 90 days after corticosteroid injection, as previously mentioned in the update for infections. One good study, 2023, Beck et al., they looked at the question the need for resecting 1 or 2 slips, but basically they looked at 1 slip of the FDS with regards to trigger finger release of those patients with PIP contracture. And this study kind of helps support abandonment of this practice at a certain point, but they randomized 55 patients with PIP contracture greater than 10 degrees to an open A1 pulley release or the excision of the ulnar slip of the FDS. And they were able to show that at 2-week follow-up, group 1 had the group that only had the A1 pulley release only had significantly clinically meaningful better strength. At 6 weeks, there was no difference in degree of contracture, pain, or function between the 2 groups. And as we can see here in the graph, they kind of all even out at the year. So it kind of comes to question. And some of these, though, that if you look at this study carefully, what would question those PIP contractions that go up to 30 degrees, because they were greater than 30 degrees, they had the recurrence with regards to their contractures, and questioning the need for an FDS excision in less than 30 degrees of contracture. Masserani found that within a year of trigger finger diagnosis or intervention, patients treated operatively for a trigger finger were more likely to develop and be treated for Dupuytren's disease. Again, this shows, the correlation that some patients where you have a trigger finger release, they have a recurrence of a Dupuytren's nodule. And again, this data does confirm that the relationship within Dupuytren's disease and trigger finger as well. Last but not least, just paying attention to the risk in 2021, Morrissey et al. And Dr. Steve Moran, they looked at the vascularity of the scaphoid with greater sophistication, and they were able to show that the vast majority, 83% of the scaphoids, also demonstrated 2 distinct scaphoid morphologies, with one having a less robust network of interosseous vascularity. So they looked at the slender type scaphoid tended to have less robust network of the interosseous vascularity as compared to the full. Pet et al., they reported 21 patients who received osteochondral free flap from the medial femoral trochlea to treat proximal pole non-union. They were able to show union in all but one patient. There was one reoperation for thrombosis. Decreased patient-reported outcomes for donor function were noted, but these changes did not meet threshold for clinical importance. This led to this study in summer 2021 by Summercamp that advocated for the palmar radiocarpal artery vascularized flap, and they were able to show in 15 cases with humpback deformity and a vascular proximal pole, they were able to show good results. In all their cases went on to osseous union, and the radiocarpal alignment was improved. One thing with scapholunate chronic reconstructions, the modification described by Sando and Fisher, which presented a novel reconstruction technique known as the anafab, where you weave a double strand of suture tape anchored to the trapezium and a distal base strip of the tendon autograft FCR from volar to distal within the scaphoid, then passing it from dorsal to volar through the lunate and anchoring volar to the radial styloid, as shown here, with an interference screw. And again, they were able to show at 2 years of reconstruction provided restoration of static scapholunate stability as measured on radiographs. And what this comes in is that we're not only addressing the coronal plane, meaning the widening of the scaphoid and the lunate, but also that sagittal deformity, which leads to addressing, as stated, not only the diastasis between the scaphoid and the lunate, but also the flexion pronation, the proximal posterior subluxation of the scaphoid, and extension and possibly ulnar translation of the lunate. And this reconstruction addresses all of these facets of the deformity of scapholunate dissociation. Blackburn et al., they looked at the Garcia Elias described 3 ligament tenodesis in 2003 patients, consortium of 20 surgeons. They had reasonably good results. About 1 year, 80% of the patients did well, but 10% had no change and 11% had worse patient-reported outcomes. So still, the 3 ligament tenodesis is still a powerful tool to have in your armamentarium as you're treating these chronic scapholunate ligament insufficiencies. One thing that Park et al. Demonstrated that specimens with suture tape augmentation had a higher to-load failure to those treated with repair alone. They tested the perpendicular to the SL ligament, and authors assessed tensile strength in the coronal plane only, and did not evaluate the response in other planes, which also leads to the other size deformity, other forms of deformity that you have within the scaphoid and the lunate in different planes. But in those patients that you may have a tenuous dorsal ligament repair, they still have some intact volar hinge of the scapholunate ligament. This may be a good suture tape augmentation technique to have, a good tool to have in your toolbox as you're addressing this deformity. One thing about practice management, within our team here, Dr. Apel and their group here at Virginia Tech, they were able to do a nice simulation study that showed that driving is theoretically not impaired with a bandaged numb in hand. So especially with wide awake surgery, they were able to show the patient adapt quite nicely to their numb hand while driving. Baxter et al., their surveyed use supplies in hand surgery across 35 U.S. surgeons in 19 centers to assess variation. And basically, they determined that with judicious use of 10 key items, carbon dioxide emissions could decrease by 10.9 kilogram per procedure. So again, this is one of the environmental impacts that we as hand surgeons can have in our environment. And this definitely has been a surge in the interest in our hand upper extremity field and practice. Vincent et al., they highlighted again the importance of patient education, which reduced the number and duration of pills taken, but there is still a grave overprescription of opioids, as they report approximately 50% of prescribed pills went unused. And patients do report a higher satisfaction with better comprehension, safer opioid use, and increased utilization of exercises with video materials compared to written handouts, so it may be something to incorporate in your practice. Here we're demonstrating the evidence-based articles for 2023. One is by Young et al., where they looked at steroid injection in both compartments. Is it more effective than a single compartment, subcompartment injection alone for Decker veins disease? Is a good reference article. The Lawson et al. Group, which is known as the Crossfire study group, they looked at distal radius in the elderly patients, and they were able to support the existing evidence that non-op management of distal radius fractures in the elderly population restores patients to normal function with minimal risk and lower cost than a volume lock-in plate. And then the cell studies would look at volar plate fixation versus cast immobilization in acceptably reduced intertrigo distal radius fractures. Definitely, these are good articles to reference. Thank you for your time, and hopefully this has been a very helpful review of the current literature. Thank you.